dermis. They appear at puberty and they increase in number. It's thought the cell of origin is peripheral Schwann cells, and 99% of adult patients are said to have a cutaneous neurofibroma. Plexiform neurofibroma is one of the other diagnostic criteria. These can be easy to recognise if they're superficial. They occur in about 50% of patients with NF1. Often, as you can see in this picture here, on the large plexiform neurofibroma involving the medial surface of the left upper arm, you can see that there's pigmentation over the surface. When you feel these areas, they often have this sort of curious feeling like there are lots of cords underneath, which result from the hypertrophied nerve fibers in this area. So there's sort of the bag of worms type feeling. And often what you'll see is early on, you'll see an area of pigmentation, and then because the plexiforms tend to develop during early childhood, you'll actually see that the plexiform swells out, and growth prior to puberty is allowed and usually doesn't represent malignancy. The skin pigmentation itself is often a clue to an underlying plexiform neurofibroma, which may extend a fair way back, sometimes to the spinal cord. The patients who are more concerning, patients who have these very extensive plexiform neurofibromas. So this is a patient of mine who's got very extensive disease. This is a whole body MRI. And what I've done is I've highlighted on one side the regions which are plexiform neurofibromas. So this is all nervous tissue here, which is hypertrophied and passed to plexiform. So you can see this cervical, thoracic plexiform neurofibroma extending down towards the arm. You can see in the lumbar region, sort of in the region of the lumbar plexus, there's significant hypertrophy of the nerves. And then if you look at the pelvis in this area here, you can see there's a lot of plexiform tissue. And in the middle, there's an area which is really quite unusual and proved to be an atypical neurofibroma. So people who have very bulky disease can have lots of plexiform neurofibromas. The plexiform neurofibromas are a problem if they are growing in a place where they've got cosmetic effects such as around the orbit, or alternatively, locally, they actually may compress important structures. So this boy had problems, has real problems with his continence because his pelvis is largely occupied by plexiform neurofibromas. And one of the important things about these is plexiform neurofibromas come with a risk of transformation into the malignant peripheral nerve sheath tumours. Okay, the next diagnostic criteria, and one we have to think about, are optic pathway gliomas. They occur in quite commonly in about 15 to 20% of people, in fact, really children with NF1, when you biopsy them, and you usually shouldn't biopsy them, but they are grade 1 pilocytic astrocytomas. They occur most commonly in children under 7 years of age and very rarely develop after puberty. So practically, we continue ophthalmological surveillance until 10 years of age, and I'll come to what we actually do with that later on. They don't always need to be treated. We treat them when there is a deterioration in visual acuity, when there's a loss of visual fields, but only about half of them need to be treated. Practically, what this means is, though, it's important when you're seeing a child with NF1 that you check vision at each visit. So be concerned when a child with NF1 presents with new onset strabismus or proptosis. And in younger children, just what I tend to try to do is to occlude one eye and see whether they object to it, because that may identify a problem. I guess one of the challenges of optic pathway gliomas is they will develop in children before you actually necessarily know they've got NF1, because the other sides may come up. Other signs may be slower coming up. So you've got to watch these younger kids with cafe au lait spots closely. This is a girl who presented to me with a new onset strabismus. When we examined her, she had cafe au lait spots and axillary freckling. So she met the clinical diagnosis of NF1. And what you can see in the MRI on the left is there is a very large optic nerve glioma, which basically fills most of the orbit. You can see how the globe is flattened and how it's pushed forward with proptosis. The same girl, an MRI now in the coronal plane, and you can see on this side, this is the normal optic nerve. On this side is the very swollen left optic nerve. So you can see that these lesions can be quite large, and this girl just presented with this lesion, not known to have NF1. Lisch nodules, these don't cause any problems, but are an important diagnostic criteria. You need to have more than 2 nodules. What they are, they're iris hematomas. And the important thing about them is you need a slit lamp to see them. And that's because these are 3D iris nodules. So a lot of people will have some pigmentation on their iris, what our ophthalmologist refers as iris freckles. But in the case of Lisch nodules, they are little 3D nodules. You can see the arrows pointing them. Choroidal abnormalities have been more recently described. You apparently need to have a scanning laser ophthalmoscope, which I don't, and they're identified using near infrared reflectance, and they show up as being sort of hyper-reflective spots, I guess a little bit like the equivalent of cafe-au-lait spots, but at the back of the retina. The osseous lesions, these images are taken from Legia's paper, but what you can see is tibial bowing in this view. In this image here, you can see there's pseudoarthrosis of the tibia and fibula. These can be really difficult problems to treat orthopedic. In this image here, another dysplasia, a dysplasia of the ulna with some bowing of the radius. And here is a CT scan of the brain, which shows that the normal sphenoid on this side is intact, but on this side you can see the bone is lost, and this is sphenoid wing dysplasia. Again, images taken from the Legia's paper. So I want to talk about now some of the common problems in NF1. I've already talked about optic pathway gliomas. We're not sure how much detail will come into that, but we'll spend a bit of time. So one of the practical issues is that neurocognitive impairment is a really important part of NF1. And if you look at intelligence, overall, the IQ of children and adults with NF1 is about a standard deviation below the mean compared to unaffected siblings in the population. But there are some specific problems. So there are some specific learning disorders. About 3/4 of the children with NF1 will need extra learning support. Most commonly, they have problems with areas such as reading, mathematics, writing, and spelling. And it's very interesting. They do have some very specific visuospatial problems, which can make maths much harder. Attention ADHD is really quite common, and most commonly they will have inattentive ADHD, which is a bit of a challenge because kids with inattentive ADHD don't stand out quite as much as the classroom. They're the kids who tend to be daydreamers, and so they're not as well identified as those children who cause more problems in the classroom. And there's some evidence of effectiveness of methylphenidate. There seems to be a structural basis to the learning problems in NF1. We did a study which looked at the thickness of the corpus callosum in NF1, and we found that increasing thickness of the corpus callosum was associated with a significant lower IQ and quite a worse performance on a range of neurocognitive measures. So the neurocognitive profile is quite characteristic. It's quite a major issue. Okay, more recently, people have become aware of some of the behavioural and psychiatric problems in NF1. So autistic spectrum disorders seem to be more common in NF1. And the other thing too is that a lot of the children, whilst they don't quite make criteria for autism, have a range of behaviours which are consistent with features of autism. So they'll have social communication impairment. They may have restricted interests or repetitive behaviours. And whilst they may not meet the criteria for ASD, they have some features. And there are also reports of increased rates of anxiety and depression in this group of children. So it's important to keep an eye on that aspect of development. Hypertension, another important and common problem, not so common during childhood. So primary hypertension, there's an increased risk during the childhood, but it's not that common, but it becomes increasingly common during adult. What you do tend to see in childhood a little bit is the secondary hypertensive, and that's partly because of renal artery stenosis, because there is vascular involvement in NF1. And I've certainly got one child who's got hypertension due to renal artery stenosis. There's also an increased risk of pheochromocytoma, and I think I've had one child with that too. Breast cancer. Again, for paediatric neurologists, not such an important issue for our patients. However, it's a very important message for young adults and also the mothers of their children with NF1. Just have a little sip of water. The breast cancer risk is considerably increased. It's 5-fold increase compared to the general female population. The median age of diagnosis is younger, it's 46 years. And unfortunately, people with NF1 tend to present with more advanced disease. So the recommendation, certainly for young adults, is that they should have annual breast screening from 30 years and they should perform breast self-examination. It's certainly something that you should talk to mothers with NF1 about and certainly old adolescents. Other common problems. So the other common problems are headache. So headache is very common in NF1. It's seen in about 10% of children. Often the headaches themselves will have migrainous features. The challenge about this is because we all worry about brain tumours. A lot of these kids in Australia end up having an MRI. The challenge about it is when you do an MRI, you often find something you have to worry about, but it's not always the major cause of the problem. Pain is a major problem. It is perhaps not a major problem, quite a common problem in NF1. There are a couple of reasons for pain. One of the more common reasons is that you'll get neuropathic pain associated with plexiform neurofibromas. This tends to respond to drugs such as pregabalin or gabapentin, but it can be a bit of an issue. Itchy skin, another common problem. It's actually quite a nuisance for some of the kids. A lot of the children with NF1 will have dry, itchy skin. And then if you have a neurofibroma, the neurofibromas themselves may become itchy due to irritation pressure. In fact, mast cells are sort of quite represented in the cutaneous neurofibromas. And so when they get pressure on the neurofibroma, they can be quite irritated. And then cosmetic issues, cutaneous neurofibromas become an increasing issue after puberty. And then plexiform neurofibromas, especially if they're facial, can be very disfiguring. And then we can talk about rare but significant problems in NF1. So we've talked about some of the cosmetic problems related to plexiform neurofibromas. We've talked a bit about optic pathway gliomas. I'll talk about surveillance later on. But the other topics we'll cover are scoliosis, brain tumours, vascular disease, spinal cord compression. I won't talk too much about puberty, except to say that in patients with NF1, it's very important to monitor puberty, particularly for those children who've got some hypothalamic disease. They may either have delayed puberty or precocious puberty. So it's important to watch both puberty and growth. So scoliosis. The incidence of scoliosis is a bit unclear. If you look at papers on it, it says the incidence is somewhere between 2 to 10%, but it can be a really big issue. The scoliosis can be dystrophic due to bony abnormality, and if that's the case, it can be rapidly progressive. On the right is an MRI of a patient of mine with quite a severe scoliosis. What I've highlighted in blue is a plexiform neurofibroma, and what can be seen is this plexiform neurofibroma is adjacent to some very dysplastic looking vertebrae. So these are vertebrae. You can see the vertebrae coming up here, and then at this level here, what you can actually see is the spinal canal. And one of the things that you might note on this scan is the spinal canal is actually very wide, and you get the impression on this image here that the spinal canal is very wide. On the blue line, this is the spinal cord, and this is the spinal canal here. And this person not only has quite a significant scoliosis, but has quite major dural ectasia, has a very rapid cervicothoracic scoliosis. And these are very difficult to treat because the bone's abnormal and the position's very abnormal. So these are big problems, the scoliosis, and they can progress rapidly. So if you've seen, always check for scoliosis and just watch for progression. But there's also an increased incidence of non-dystrophic scoliosis. So the more typical adult scoliosis, this tend not to be as rapidly progressive. So watch out for scoliosis. Now, I want to talk a little bit about the typical NF1 changes on MRI, because these are important and they're often confused with tumours or other growth. So it's important to know, if you get scans on children with NF1, what the typical scan shows up. So the first thing to see on the MRI on the left, where the yellow arrow is, you can get thickening of the corpus callosum. So that's quite common. Then, in terms of the cerebellum, you'll often see these T2 hyperintensities, which we sort of refer to as unidentified bright objects. They're fluffy lesions, usually deep within the cerebellum, but they also can see lesions. Here's a lesion, another patient with NF1 with lesions in the globus pallidus, a very common region, but you'll often see them sometimes in the brainstem. If you look at the temporal lobes, you'll often see high signal in the medial temporal lobes. The important things about these lesions are they're high signal on T2, they shouldn't have any significant mass effect, and they usually don't show contrast enhancement. So be anxious if they've got mass effect or contrast enhancement, because that's a marker that it might be a tumour. And here's a patient of mine who has a number of pilocytic astrocytomas. So this person has a pilocytic astrocytoma, which is involving the left cerebellar hemisphere extending into the left cerebral peduncle. He's also got a pilocytic astrocytoma here of the cerebral peduncle on the right, and he actually had further tumours further up. Typically, the tumours are pilocytic astrocytomas, but they're multifocal. Unfortunately, you can also, there's an increased rate of higher grade gliomas. Kids with NF1 have a significantly increased risk compared with the population, but fortunately overall, most of the tumours we see are pilocytic astrocytomas. The thing that we worry most about in terms of malignancy are malignant peripheral nerve sheath tumours. These usually develop from plexiform neurofibromas, but they may occur de novo, and they're surprisingly common. If you follow people for longer, they develop in about 8 to 15% of people with NF1. Given that people will have a lot of plexiform neurofibromas, it's good to have an idea about what are the things that you should worry about that makes you think that somebody's developing a plexiform neurofibroma. The concerning signs are growth in the plexiform neurofibroma, especially post-puberty. So typically there is some growth pre-pubertally, but if there's growth post-puberty, this is a concern. And often the malignant tumours present with new pain. If you're concerned about it, we tend to do an MRI, and this is also taken from an image taken from Lyon Blakely, but there's a lesion here. One of the things you can see is that on this MRI, rather than having the signal, which is rather uniform like the atypical neurofibroma I showed you early on, there's heterogeneous signal. It just looks nasty, it looks wrong. And then if you perform a PET, there's increased FGG uptake. So this is PET avidity in this lesion here, and this is suggestive of a malignant peripheral nerve sheath tumour. These are associated with a high risk of mortality, and they need early detection. So we tell any patient with NF1, if they notice a new lump, particularly if it's painful, they need to see somebody and see somebody early, because treated with resection early on, these are more likely to respond to treatment than if you wait for them to progress. Okay, this is an uncommon but an important problem in NF1. So if you look at this MRI, it's always really important to look closely at the T2 weighted MRI. So if you look at this image, and I'm going to give you a magnified view, you can see the problem. So here's the magnified view. And it's important always, if you've just got T2 weighted MRIs, to look at the carotid arteries and the middle cerebral arteries. What you can see, this is a view now where we're looking at a magnified view of that previous image. And what you can see on the left is this is the carotid about to branch out to form the middle cerebral artery. This is the posterior communicator on the left, but on the right, you actually don't see a right middle cerebral artery, and you don't see any branches of the right internal carotid artery. Instead, you can see these little vessels. So on this person, they went on to have an MRA, and this is on the MIPS. And again, you can see the left carotid artery, but you don't see anything in the right. You go to the MR angiogram, and you can see a nice left middle cerebral, but you don't see a right internal carotid, and you perhaps get a glimpse of a very small left MCA, and on angiogram you get this. So this is the left internal carotid. You can see it abruptly stops, and there is a puff of smoke appearance. So this person has moyamoya. Moyamoya isn't that common, but I've had at least a couple of kids who've had it. The incidence is about 2%. Always check if somebody has an MRI. Always remember to look at the carotids. Even on the T2 axial image, you can often see this. And be concerned in anyone with NF1 who has a stroke-like episode, because moyamoya is a real concern, and this child needed to go on to be revascularized. Spinal cord involvement. It's important to think about spinal cord involvement. So when you're looking at an MRI of the spine on NF1, look at the intervertebral, the neural foramina. So this is a normal neural foramina, and what you can see is the nerve root poking out with high signal rounded on the T2 weighted image. This is a patient with NF1, and again, you really can't work out where the neural foramina are, and that's because this is all a dumbbell-shaped plexiform neurofibroma, and it's filling all the spaces where the neural foramina should be. So this is the neural foramina, but there's a huge dumbbell-shaped neurofibroma sitting in this space. And the reason it's important is if you've got a lot of intraspinal neurofibromas, you may get cord compression. This is a case of an 11-year-old girl who presented with deteriorating gait. She was tripping over. We noted she had weakness of her right ankle dorsiflexion, wasting of her right calf. She had a brisk right knee jerk and right ankle jerk, clonus at the right ankle, upglowing plantar response in the right, and her MRI looked like this. So this is a sagittal T2 weighted MRI of the spine, and you can see that the spinal cord is compressed here by these lesions in the front. You can see there's a bit of high signal in the cord. Again, on this image too, you can see this neurofibroma, which is pushing in anteriorly, but also bits of neurofibroma posteriorly. And when you look at this image here, you can see why there's a problem. So this shape in the middle is actually the spinal cord, and these are the plexiform neurofibromas, which are squashing their way in and compressing the spinal cord. There's also a lot of other plexiform tissue. So compression of the spinal cord is important. So I think it's really important if you're looking after kids with NF1 that you check and document reflexes in the legs, especially in those kids with multiple plexiform neurofibromas. So what do we do for pediatric surveillance? Typically, we do an initial diagnostic assessment, and we as pediatric neurologists or geneticists do an annual medical review. Early in life, ophthalmology is critical. So under 4 years of age, the suggestion is that they need to see an ophthalmologist every 6 months. Now, that may be a luxury that's not available to many people, but that's the recommendation. And then 4 to 10 years annually, it's probably best to see ophthalmologists. And then up to 10 years, every 3 to 5 years. The other message we give families with NF1 is they need to return early if there's progression of NF1 symptoms, because things are much more easy to treat if they've been going on for a short period of time than a long time. In terms of what we do, when we see somebody for an annual pediatric review, blood pressure, we check growth, check the skin, always check the back for scoliosis in the limbs, check the eyes, check visual acuity, check their fields. I tend to check extraocular movement and do fundoscopy. Follow up on their development and their learning. See how their milestones are going and how their school progress is going. Often you'll find kids with NF1 are struggling with learning, particularly reading, and they often have quite significant difficulties with socialization. So find out how behavior and their social skills are going. I think a neurological examination is important, and I think focusing on gait and cortical spinal tract signs in the leg are important, because cord compression is something that if you miss, it's difficult to get back. Some of the common questions in MF1: who do we perform MRIs on? We don't routinely perform MRIs on people of F1. We only do it when people who have symptoms suggesting neurological disease. The reason is because if you don't, then you often tend to find problems which you then have to follow with further MRIs. And typically we don't treat problems unless they are causing a clinical difficulty. So we don't routinely do MRIs. There is some debate in our group about whether we should do a whole body MRI in late adolescence as surveillance for things like covert plexiform neurofibromas. In terms of genetic testing, we don't do this routinely on people who meet criteria for NF1 unless there is a need, for example, pregnancy related. Sometimes we'll do it when we need diagnostic clarity. For example, if we've had somebody who's been borderline for meeting criteria for NF1 and we try to work out whether that's surveillance in that situation, we may do genetic testing. And sometimes we'll do it for people who have an isolated optic pathway glioma but don't otherwise meet criteria for NF1. The points I'd like to leave you with tonight are: firstly, NF1 is a disease of tumours, lumps, dysplasia, and development. I think surveillance is critical for good outcomes. I think it is a difficult disease to look after. 90% of the time it's routine, but 10% of the time it is complex, and really quite complex at times. And you really need to watch for hidden complications. And I've certainly missed things. And I think, unfortunately, there's nothing like experience in managing NF1 because it protects patients and clinicians. So look, thank you very much for your time listening to me. And I'll be happy to take questions at the end of my presentation. So thank you for listening to me.
Thank you, Richard.
Thank you, Dr. Verma.
Very interesting talk, full of experience. So let's see the next author, next speaker. And
hello, yes, sir.
Next
speaker, please.
Yeah.
We'll take a question and answer after all talks.
So, Sandeep, are you introducing or shall I introduce?
So you can.
Okay, so I have great pleasure introducing Pragna Gadgil. She is well trained in fellowship in neurology and epilepsy at Great Ormond Street, a consultant pediatric neurologist at the Kopilabh and Dhirubhai Ambani Hospital. She is the director of the Tuberous Sclerosis Clinic. This is probably one of the very few ones running in India, and these are the experienced epilepsy, stroke, and tuberous sclerosis. So we look forward to hearing from you, Dr. Gadgil.
Pradnya, are you there? You are muted. And can someone unmute her? Yeah. You're good.
I'm just saying it's a huge honor to be introduced by Dr. Verma. So a special thanks to ORDI and AOCN for giving me this opportunity. Can you see my screen?
Yes.
Thank you.
Maybe you need to enlarge it to show the full art. Good.
So I'm going to try to translate the advances that have happened in tuberous sclerosis and see how and why we should apply them to our bedside practice. As we all know, tuberous sclerosis complex is a neurocutaneous disease. It's a multi-system disease which It's primarily caused by formation of hematomas in different organ systems, the brain, the skin, the heart, later on the kidney and the lungs. It troubles pediatric neurologists a lot because it very often presents as a severe refractory epilepsy, often starting with infantile spasms. The kids often have severe autism or at least severe developmental delay. And these are kids who are challenging to handle in the long run. Also, TSC has a very natural history which evolves over time. And so it's a pretty labor-intensive disease where you need multiple specialists to work together. And I think that is possibly what's given rise to the concept of a TSC clinic. So with that background of a multi-system disease, there are very nice diagnostic criteria which have been laid out. They were last published in 2012, and I think we are looking forward to the updated diagnostic criteria. They were supposed to come in 2020. So the current criteria as they hold, either you have a genetic diagnosis, if you have a pathogenic mutation, then you have TSC, or you have clinical criteria, of which if you have two major or one major and two minor, then you are clinically diagnosed to have TSC. And you can have a clinical diagnosis without performing genetics, which is, I think, important to know for our population. So the TSC story is something I'm hoping to take you through this evening. It's a very interesting story, and it started off with the discovery of the TSC genes in the late 1990s. The understanding the TSC genes and the mutations which cause TSC led to quite an exciting journey, which helped people understand the loss of function that was caused by these mutations. What was this function? What were the cell signaling pathways that were controlled by these by the intact TSC genes? And this helped to understand the tumor growth. And this gave a chance to come up with targeted drug therapies for TSC. And I'm going to try and bear with me. I'm going to try and take you through the basic science of it in a simple way. This discovery is not only exciting for TSC, of course, it serves as a prototype disease, but it has such varied implications in oncology, where a lot of cancers are, their growth is controlled through the same pathway, the mTOR pathway, and even diabetes. So let's just quickly look at the basics of TSC genetics. So we know TSC is caused by mutations in TSC1 and TSC2, which are naturally tumor suppressor genes. TSC1 is on chromosome 9, inherited autosomal dominant. TSC2 is on 16. These are mainly sporadic germline mutations, but we know TSC2 mutations results in a more severe clinical phenotype of the disease. These genes show complete penetration, but they can have variable expression. So, in a family, it's not necessary that the clinical manifestations of the disease are similar. There can be some, the parents may not have any cortical dysplasias, any tumors, and may be relatively intact. Have children who are affected and early with spasms. And then you realize that, oh, it's actually a dominantly inherited disease with the parents being dominant. Lot of mutations have been described in both the genes. A practice point while I'm on the genes, again, it's important to know that up to 25% of patients who fulfill the clinical diagnostic criteria of TSC may not have an identifiable mutation in the genes, but they are still to be managed like any other TSC. However, if you have a pathogenic mutation demonstrated in the TSC1 and 2 genes, then that patient has TSC, irrespective whether they fulfill the clinical criteria or not. And this is important to institute surveillance. As you know, somebody who's asymptomatic early on can go on to develop renal, if it's a lady, or lung manifestations in later life. And again, of course, it's important for antenatal counseling, especially in the ones who are binary affected. So now that we know, we've learned a little bit about the TSC1 and 2 genes, how do mutations affect function, cell function? So TSC1 and TSC2, the traditional function is tumor suppression. one way they suppress tumors is their association to the mTORC1 complex. mTORC1 is a complex of 3 proteins which comes together. Now, if you have mutations in TSC1 or TSC2, the mTORC1 activity becomes aberrant. So normally it suppresses tumors. Now this inhibition is gone away and mTORC1 just keeps driving cell proliferation and hence drives tumor growth. And this is thought to be one of the important ways, pathways, which gives rise to hematomas in multiple organ systems in TSC. But this also sets up mTORC1 as a potential drug target. So the same concept in a simplified cartoon. On your left here, you have your normal mTORC1 signaling. TSC2 has an important domain called a gap domain. When it connects with TSC1, the two of them together keep this Reb protein, which is a G protein, inactivated. Because if it's active, the mTORC1 loses inhibition and causes cell growth. So keeping Reb inactive keeps the mTORC1 inhibited. But now when you have TSC1 and TSC2 mutations, Reb doesn't stay inactive, Reb becomes active. And there is loss of inhibition on mTORC1, and that just drives a lot of abnormal cell growth, i.e. tumor growth. Hence, if you are able to inhibit the end step, if you are still able to inhibit mTORC1, then you will be able to control that cell growth. And this lends mTORC1 as a potential target for drug therapy. Thankfully, when this was realized, we already had a drug called rapamycin, which was actually initially recognized as an antifungal drug. And the mechanism of action was that it was an mTORC1 inhibitor. So this very quickly got repositioned from an antifungal to a possible treatment option for TSC. However, is it only rapamycin? No. So rapamycin or sirolimus, and now another drug called everolimus, which is again a very similar mTORC1 inhibitor, are the first generation mTORC1 inhibitors available, FDA approved for treatment of SEGA, renal angiomyolipomas, as well as epilepsy, medically refractory epilepsy in TSC. But there are second and third generation mTORC1 inhibitors in the pipeline. Second generation ones may be more toxic, but the third generation mTORC1 inhibitors may be more selective in inhibiting mTORC1 and not mTORC2, which is a downstream protein complex, and that might lead to better clinical efficacy. However, is this the holy grail? Not really. There are quite a few limitations of using mTORC1 inhibitors in TSC. Firstly, all of TSC pathology cannot be attributed to the mTORC1 hyperactivity alone. Just the TSC1 and TSC2, one way of tumor suppression, yes, is through the gap protein, through the Rep protein. But then there is another domain called the TA domain, which is what actually comes into action in LAM. Then there's a very robust two-hit model hypothesis, which say that these tumors are formed because, yes, you have germline mutations in TSC1 and TSC2, but additional somatic mutations then trigger the formation of these tumors. For example, in facial angiomyofibromas, where UV light exposure is thought to create somatic mutations in the diseased cells, which give rise to facial angiofibromas only in sun-exposed areas. Also, rapamycin can only partially inhibit mTORC1. It doesn't completely inhibit mTORC1. And also remember, while you're giving rapamycin or everolimus, only while it's on, it's effective, because all it does is it controls the tumor growth, because it only partially inhibits mTORC1. So it keeps the tumor growth controlled while the medicine is being administered. It does not regress these tumors completely. So it's thought that these medicines will be required for a very, very long term in most TSC1 patients. So then, are there any other therapeutic options? Does understanding the cell signaling pathway give rise to any other options? So there is another set of drugs which looks very promising, and these are the endoplasmic reticulum stress inducers. Just bear with me; it isn't as difficult to understand as it sounds. Let me simplify it. So the TSC tumor cells are very, very susceptible to energy stress, to ER stress. the baseline level of cellular activity and energy consumption is very high. And the minute it crosses a certain threshold, the cell dies. So then if you have medicines or drugs which can worsen that ER stress, the energy stress, then they will potentially kill off the TSC disease cells. And remember, normal cells who don't have the mutation can very well tolerate high levels of energy stress. It's only the TSC disease cells which will not be able to tolerate it. So now this gives a great opportunity to use these medicines to kill off disease cells, i.e. completely regress the hematomas. So there have been very promising in vitro studies published quite recently. The drugs which have been shown to work as ER stress inducers are nelfinavir and antiviral. I've forgotten what bortezomib is, and good old chloroquine. Now, when you say chloroquine, somebody, for countries like us, I so hope that it proves as promising in vivo as it looks in vitro, because that will really throw up a very inexpensive, straightforward treatment option for TSC patients in our country. Another very exciting development is understanding activation of AMPK. Again, not tough, just stay with me. Now the pathways which are regulated by mTORC1 are, again, as I said, they're highly energy consuming. Now, when energy levels dip, you consume a lot of energy and your energy levels dip, then AMPK becomes activated. Why is AMPK important? Is because AMPK actually stimulates autophagy of cells. So mTORC1, remember, inhibits autophagy. That's why you have cell growth and tumor growth. AMPK stimulates autophagy, which means your cells will die out. And then that could mean that your tumors will not grow, or the growth will be limited if we are able to stimulate AMPK. And there has been a very promising clinical study with metformin, and I'll talk about it in a second. So now, with this background in basic science, I promise that's the end of basic science here. How does it change our clinical practice? So let's have a quick look at the clinical trials which have used this basic science. So I think one of the very first ones which got published in 2016 was the EXIST-1, which looked at the use of everolimus and its effect on SEGA. And it found that everolimus leads to sustained reduction in tumor volumes, and not just tumor volumes of SEGA, but also of renal angiomyolipomas. And the safety profile was thought to be acceptable as well. These studies continued, and a landmark study was the EXIST-3 study, which looked at everolimus and its effect on epilepsy in TSC. This was a large international study, and remember, it was a very disease cause-specific drug trial. Otherwise, most trials in epilepsy are, based on focal seizures or generalized seizures or genetic generalized epilepsies. This was a very TSC-focused study looking at effect of everolimus on epilepsy in TSC. Large study recruited 366 patients. Looked at placebo, low exposure, i.e. low drug level, low serum levels of everolimus versus high exposure, i.e. high serum levels of everolimus. And the results were very encouraging. More than 50% seizure reduction seen in almost double number of patients in low dose, and even higher in high exposure everolimus drug arm. It also showed a cumulative effect, and I think that's very important. So they did pharmacokinetic modeling, and they showed that for every 15 days of treatment delivered, there was an additional 5% reduction in seizure frequency. So a cumulative anti-epileptic effect was seen with time, which is not seen with any of our traditional anti-epileptic drugs. So this was a landmark trial because this extended the use of everolimus to drug-resistant epilepsy, but not as an anti-epileptic drug, but as a disease-modifying drug, which is what we all of us are typically looking forward for in therapeutics. And it also led to FDA approval of everolimus for refractory epilepsy in TSC. But this was for older children. So then there was a small study published saying, can you give everolimus to the younger ones? Because very often we see epilepsy starting in the first few months of life with focal seizures and infantile spasms. Sometimes the development is normal, and then you see autism setting in, developmental delay setting in. So this was a small case report of about 17 children who were given everolimus as young as 5 months of age for various reasons, for SEGA, for cardiac rhabdomyomas causing cardiac failure, for severe epilepsy. It was a retrospective descriptive study, and they found that in children less than 2 years of age, everolimus was safe. There were no grade 3, grade 4 adverse events reported in these very young babies. And that's quite encouraging for a subset of patients who can have very severe TSC presenting very early in life. Because again, everolimus is disease modifying. So can you pull it even further? Can you give everolimus much earlier? Can you use its effect if TSC is diagnosed antenatally? So this is a case report which sounds quite encouraging. So sirolimus, maternal sirolimus was given because the antenatal scans diagnosed progressively growing cardiac rhabdomyomas in the fetus, which was causing hydrops fetalis and supraventricular tachycardias. It showed, the rhabdomyomas showed intrauterine regression of the size of cardiac rhabdomyomas, very promising. Then of course, after baby was born, the sirolimus was stopped. The rhabdomyomas showed regrowth, again reinitiated, again stopped, again showed regrowth. So this particular child continued on sirolimus. Remember, it started receiving sirolimus antenatally because the mom was given sirolimus. And at 9 months postnatal follow-up, this baby had no brain lesions, no seizures, had a normal EEG, and had normal development. I don't think this can be a one-off because we already know that mTOR inhibitors are disease modifying in TSC. Of course, you need to understand what are the dosage, what's the efficacy of placental transfer, and of course, a lot of more work needs to be done to study the safety profile of the mTOR1 inhibitors in the fetus and for the mother as well. Then let's talk about the very exciting trial recently published about metformin, an AMPK activator in TSC. So this was a randomized double-blind trial, recruited about 51 patients, and they were followed up for 12 months. The primary outcome actually was to study the effect of metformin on the size or the volumes of the renal angiomyolipomas. And surprisingly, they found that there was no statistically significant change in the renal AML volumes with metformin administration for 12 months. However, they undoubtedly studied SEGA and epilepsy as their secondary outcomes. And metformin showed a striking effect on the reduction in size of the SEGAs. And it's important to note that this effect was even seen in the younger subset of the included population, because we know the SEGA growth tails off after 30 years of age. The maximum growth occurs between 5 to 15 years of age. So even in that age population, metformin had a striking, statistically significant effect on the growth of SEGAs. It also showed significant seizure reduction in patients who had epilepsy, but however, only about 70% of patients kept strict seizure diaries. So I think this is an aspect which should be studied in further detail because it's very exciting. Metformin is a safe drug. It's been used for ages in patients, young adults and adolescents and adults with type 2 diabetes. We know it's safe. We know it's inexpensive. It's also been shown to not interact with other anti-epileptics, with other mTOR inhibitors. So of course, we don't understand what dose we should give. Why did it not affect the AMLs but affected the SEGA? Why is there so much of a difference in its effect on different hematomas? But maybe we could use it with the other mTOR1 inhibitors, maybe an everolimus metformin combination, which will help us keep the side effects of everolimus low, using a low dose, if we are able to complement the anti-tumor growth effect with metformin. So this is a very, very exciting clinical trial recently published. Of course, no talk on epilepsy can happen without talking about CBD oil. Of course, we don't know the mechanism of action of CBD oil, but we know it's FDA approved for use in Dravet syndrome, for use in Lennox-Gastaut syndrome, and TSC-associated refractory epilepsy in children older than 1 year of age. So there have been quite a few landmark trials done by Elizabeth Thiel's group. This is the latest GWP SCARE 6 trial, which not only looked at the safety profile, but also looked at what dosage of CBD oil is effective for TSC-associated epilepsy. They had 3 groups: placebo, CBD 25, which was a group which was given CBD oil at 25 milligrams per kg per day, and another group at 50 milligrams per kg per day. And they found that both the dosages were equally efficacious in reducing the seizures as compared to placebo. However, the smaller dose led to fewer adverse events. That's quite intuitive. The adverse events of CBD, just to revise, is diarrhea, somnolence, elevated liver enzymes. So a 25 milligram per kg per day dose was as effective as a 50 milligram per kg per day dose, and way more effective than the placebo in reducing seizures in medically refractory epilepsy of TSC. So now we've looked at treating epilepsy in TSC, but can this, understanding the natural history, can it help us in preventing epilepsy? I mean, we are all looking at prevention of disease. I mean, that's the holy grail, so to say. So this is the initial part of the PREVENT trial, published work done by Sturge-Weber and group. And this showed, this looked at a small group, 14 patients who received vigabatrin when the EEG started showing abnormalities in the first year of life, as opposed to 25 patients who received vigabatrin in the typical way after the appearance of infantile spasms or partial onset seizures. Now, this is interesting. These were followed up for at least 5 years. Some followed up as long as 8 years into the treatment of vigabatrin. So yes, it's a small study, but the results are very impressive. 50% of patients in the preventive group who received vigabatrin on seeing EEG abnormalities before experiencing any clinical seizures, eventually at 5 years follow-up, never had a clinical seizure. 50% in the preventive group never had a clinical seizure, as compared to only 1 of the 25 patients who received vigabatrin later on. So this study sort of set the stage for a possible preventative role of vigabatrin in epilepsy caused by TSC. There was another study underway at the same simultaneously, which is the EPISTOP trial. Results were published recently. These enrolled about 54 patients. They had serial 4-week EEG from birth. Vigabatrin was introduced at the outset, the minute epileptiform abnormalities were noted on EEG, before clinical electrographic seizures. They were followed up for 2 years. So they found that the time to first clinical seizure was much longer. So the onset of epilepsy was delayed in patients who received vigabatrin with EEG abnormalities, as opposed to how they would receive it conventionally. But more importantly, at 2 years follow-up, preventive treatment reduced the risk of clinical seizures, undoubtedly reduced the risk of drug-resistant epilepsy, and reduced the chance of infantile spasms. Now, this sounds extremely promising. This is game-changing, and we hope that this practice comes up in the recommendations of standard treatment or management of early TSC. Because this now positions vigabatrin, which we all look at as a traditional anti-epileptic medicine, this positions vigabatrin given early in an anti-epileptogenic role. So we are actually starting to influence epileptogenesis in TSC. So with all this clinical trials, how does it change our clinical practice? How does it change what we do with the patient? So these are our traditional, just to quickly revise, this is what we used to do traditionally. Epilepsy, if it starts, we give vigabatrin and thereafter anti-epileptic drugs like any other refractory epilepsy. For SEGAs, the traditional treatment option was surgeries. Often they require recurrent surgeries with shunts. Renal AMS, again, would require recurrent surgeries. Risk of renal carcinoma was high, would require surgery and chemo, and so on. So basically, what we traditionally did with TSC was symptomatic treatment. However, now, one of the biggest changes that's happened, and this is not new. The concept of TSC surveillance has been around. Having understood the natural history enables us to be one step ahead of different disease manifestations in TSC. But how can you be one step ahead? Only if you institute a very dedicated surveillance program. So these are the recommendations of 2012. Like I said, the latest recommendations are expected soon, and we will share them as they come out. But please, when you diagnose a patient with TSC, please institute TSC surveillance. If you diagnose a SEGA, you should diagnose it because now you are surveilling, you are doing an MRI brain 1 to 3 yearly in the younger patients. After 25 years of age, you don't need to because the growth of SEGA is noted to tail off. So MRIs like this, looking like this, should hopefully become a thing of the past. Here you can see a large SEGA indenting the left lateral horn of the lateral ventricle. So if you identify an asymptomatic slowly growing SEGA, introduce everolimus, but continue surveillance with respect to MRIs, do drug levels, keep an eye on the ophthalmology, and of course, a clinical check for the adverse effects of everolimus. But of course, if you do identify an acute symptomatic SEGA, then it's good old resective surgery with or without a shunt. But like I said, surveillance, regular surveillance scans should prevent a clinical scenario of an acute symptomatic SEGA. While I'm on everolimus, just a slide about practice points. What's the dose of everolimus? The recommended dose is 4.5 milligram per meter square per day. If it's a younger child, start higher at 7. Monitor the drug levels. Aim for drug levels of 3 to 8 nanograms per ml. And remember, long-term use is needed because repeated discontinuation results in the regrowth of those tumors. So do keep that in mind. The common side effects, which can be managed conservatively, are stomatitis or mouth ulcers, abdominal lipid profiles, and occasional pneumonias. Make sure you counsel the parents about severe side effects, which can be managed by just withholding medicines, but rarely sepsis and death should be discussed because those are the rare life-threatening side effects of the mTOR1 inhibitors. While the patient's on everolimus, do not forget to continue the TSC surveillance. Then, moving on to epilepsy, how has our treatment changed? If you have a patient, as is traditional in our country, typically TSC patients come to us with medically refractory epilepsy. Of course, first things first, always check, is it surgically remediable? And how will you know that? That's by doing a proper pre-surgical evaluation. Epilepsy surgery in TSC is an entirely different talk, and that's for another day. But do always refer them, do check out, are they surgically remediable? However, if not, then the options to add on are everolimus and Epidiolex or CBD oil as discussed. Now there are risk prediction models. Recently, the TASSERN study group has published a risk assessment model, which looks at various clinical aspects and is able to correctly predict epilepsy in 73% of patients with TSC. Till this comes to clinical use, the take home from the study is that the strongest risk predictor for epilepsy was the presence of tubers, which remember you would pick up because you're doing an MRI brain as a surveillance. And if you demonstrate certain specific pathogenic TSC2 variants were in certain patients were 3 times more likely to develop seizures. So these are the 2 clinical points that could be used in our day-to-day practice to predict the risk of epilepsy if somebody is diagnosed before the onset of epilepsy. Continuing with, if at all we are able to diagnose TSC prenatally or very soon after birth, then the recommendation should be out soon that we should start doing serial EEGs 4 weekly. If EEG abnormality is seen, it's recommended that we start vigabatrin. And the expectation is that not only are we going to try to prevent seizures or reduce the severity of the epilepsy, but also reduce the neurocognitive hit that happens with the epilepsy. And thereafter, of course, serial EEGs and treatment, conventional anti-epileptic treatments as needed. A couple of last slides. What's our local scenario? Are we really able to translate all these advances to our patients? An awful lot of the time, we are not able to do this. And that's because of delayed diagnosis. How will you facilitate early diagnosis? It's simple. There are skin lesions, the hypomelanotic macules, which if the pediatricians identify early, or if the cardiac rhabdomyomas get diagnosed antenatally, then these are simple things that could help early or prenatal diagnosis of TSC. And once that is done, a lot of measures that can actually be game changers with respect to preventing epileptogenesis or reducing the severity of the disease can be instituted. But in India, this is where we are. Our challenge still lies in early diagnosis because the common scenario is that of delayed diagnosis of TSC. So take-home practice points are realizing that early diagnosis of TSC is really a game changer for that patient. So, in your local pediatric groups, please do keep talking about it, keep spreading awareness. For instance, the pediatricians, the first responders, so to say, are the ones who should be aware so that early diagnosis is made possible. Similarly, antenatal scans, improving antenatal care could contribute to early diagnosis of TSC. If diagnosed early, please institute EEG surveillance and early Viger battering. In the long term, TSC surveillance is critical, and do watch out for the updated guidelines. The new treatment options FDA approved are everolimus and CBD oil. So do consider them when you are faced with a difficult clinical situation in TSC. Like Dr. Ann said in the introduction, we are all young. We are a very young TSC clinic. We have a huge task of trying to increase awareness of TSC so that all these advances can actually reach our patients and help them and really affect the natural course of the disease. It's all the more important, as you all know, in India, families with a difficult disease really have it tough because of lack of treatment options, the fact that all the expenses are out of pocket typically. So we are trying to one part of one small effort on our part is trying to set up a TSC registry. This is still in the conceptual stage. We're talking to the TSA India, but we hope to form a nationwide TSC registry. I know there are stalwarts here, so any suggestions, any recommendations are welcome while we start instituting our TSC registry in India. And with that, I thank you for your kind attention. Thank you.
Thank you, Pragna, for that comprehensive talk. And I think you have covered every point. And these new targeted therapies are very exciting, at least in TSC. And with the antenatal treatment or pre-epilepsy treatment is quite wonderful. So we have few patients which we are given vigabatrin before surge, before epilepsy, actually onset of epilepsy, and they're really doing well. So that is very exciting new development in TSC. Thank you for your talk.
Thank you, Sandeep.
Yeah, so I think we are running late. Sir, you want to introduce Dr. Mohammed Kunju sir? Mama sir? Sir, you are muted. Sir, you are muted. Kindly.
So Dr. Kunju is an old friend. He's a senior consultant neurologist, and I have heard many of his talks. He always gives very excellent talks. He was the head of Department of Pediatric Neurology at Trivandrum and the president of the Neurological Society of India in the Kerala sector. So I think without much ado, because we're already short of time, and he is well known among neurologists, I would request Dr. Kunju to give his talk. Dr. Kunju, are you around?
I think he is.
Must be working out his slides.
No, he's not. His slide is on. That's his slide that's on.
Where is he?
I can't see him here. So, Anne?
Just give us a minute. I'm sure the team are working.
Just see what way he is. Yeah.
Yeah, because we did figure it out earlier, and it was all in working order when we did the trial run. So if you just give the team a few minutes.
Yeah, I will just ask one question from Dr. Gadgil.
Yeah.
Dr. Gadgil, I had a patient and I was going to use everolimus, and I was told by Novartis that please don't use it because they don't have permission from the government to use it for ads. So we will discuss later. Okay. Let's have here Dr. Kunju.
Good evening. I think all of you can hear me. Thank you, Dr. I.C. Verma. As I was mentioned, from so many years we were sending and getting the genetic tests being done for spinal muscular atrophy and other, maybe way back in 1995 onwards. And I'll be sharing my slides from this. Okay. Hope you can hear me.
We can
Yes,
hear
sir.
you,
Yes,
but
sir.
we want to see your
Yes,
slide
yes,
also.
Yes. I am sharing my slides now. Okay. Yes. First of all, I must thank Dr. Ann and the organization for doing this wonderful program. And at the as the last talk of today, I'll be presenting the very simple topic of Sturge-Weber syndrome. Unlike neurofibromatosis and tuberous sclerosis, the Sturge-Weber syndrome is not that common and it is not that devastating, because all, as the pediatric neurologist you all may know, tuberous sclerosis, as Dr. Pragnya has discussed, is quite a common condition. It has got a lot of problems like intractable seizures, autism, and various other problems. But Sturge-Weber syndrome, all of you may be knowing that even though we see many cases, they are not frequently visiting us because of lack of or less occurrence of various complications. So I'll start with this picture. Can somebody just, if somebody can give an answer to this picture, just give a comment. Anybody there has given any comment there? I'm just looking at it. Okay, I'll show you one more slide.
Hemangioma with the cleft palate also.
Pardon?
I said there is a cleft palate also. Hemangioma and
Okay, is it Sturge-Weber syndrome? Can you actually the same child or a different child? Actually, it is the same child. Is it Sturge-Weber syndrome? Because of this presentation, actually, the initial pediatrician and one pediatric neurologist, and was referred to the ophthalmologist for glaucoma management. When the patient came to me, because I have a habit of being a neurologist, I take the history by taking little more time, because usually we have a tendency to make a diagnosis by taking the history. So in this case also, I took the history. And then I understood that there is this reddish discoloration in the face since 14 days of age, and red color discharge from eyes with increase in swelling of face and cheeks since 47th day of life. So that is it. So here you can see that hemangioma over the left side of the face, and when this hemangioma is compared to our own collections, here you see the difference between this picture and the other the picture on the left side. You can see that this is a real port wine stain, and this is a somewhat verrucous type of a hemangioma which is spreading throughout the face, and there is deforming the lips also, with suppressing the nasal bones. So you can see that this is not a simple Sturge-Weber syndrome. And so this is another one where again you can see that in our population, maybe sometimes it may be difficult to visualize the port vein stain or the capillary hemangioma. And so these are some other patients where again you can see that capillary hemangioma. So we'll go back to our patient. See, this was the photograph of our baby at the time of his birth. So that means we can see that the angioma or the port vein stain was not there on the face. And then you see this has happened because when okay, when I'll show you the face now once again. Okay, so this is the face at birth, and now you see what has happened to his face. So there is a postnatally enlarging a segmental craniofacial hemangioma. So it is more of a verrucous type of hemangioma when compared to the. So the other examination, you can see large facial hemangioma in the left side of the face and nose extending the left scalp region. The nasal was disfigured along the nose left ala nasal and a defect extended from the columella to the philtrum of the upper lip. Secondary clefting of the upper lip, swelling over the cheek, and no sternal defects were also seen. So we will be doing an MRI. And the MRI, because initially it was sent as a diagnosis of Sturge-Weber syndrome, the radiologist gave the report as a suggestive of a Sturge-Weber syndrome. Even though this was the picture, you can see that when you carefully see that the abnormality is not in the occipital lobe, even though flexible, but it is the posterior fossa was showing abnormality because left cerebellum was hypoplastic. There was a posterior fossa cyst, and it is small also. So that means it is a posterior fossa abnormality. There is a facial hemangioma, and there are other abnormalities also. You can see that the MRI was showing a parotid enlargement also. And then an angiogram. And again, the radiologist has reported this angiogram as normal. Because here, but if you can look carefully, you can see that this is the internal carotid artery. You can see that carotid artery there, and then the vertebral artery, and then you see that the basilar artery. But you see on this left side, there is no basilar vertebral artery and the carotid artery. Both were dysplastic or hypoplastic. So that means there is an arterial abnormality also. So this was a case of somebody has given the diagnosis of Phakomatoses syndrome. So by that, because all the abnormalities were there was ocular abnormality also in this child with the posterior fossa brain abnormalities, facial hemangioma, arterial anomalies, but this child did not have any cardiac anomalies, aortic coarctation, eye abnormalities. And when the sternal defect is present, it is the syndrome is called as Phakomatoses syndrome. And because child was having a large verrucous type of hemangioma, I gave a high dose propranolol. And see, after 2 months of treatment, child has come back completely improved, except that so you can see that the clefting has also healed, and now the faces also can be seen. So that means even though we make a diagnosis, this sort of thing has happened to me earlier also, where there was another hemangioma, where again, because hemangioma was growing into the eyes, again the ophthalmologist was going to do a surgery because so whenever we think of a common thing, you have to look at the other aspects. In this case, actually the history as well as the finding that it is not a capillary hemangioma, we gave the diagnosis, because if we are going to rely on the radiologist report of MRI as well as angiogram, we would not have diagnosed this case, because the report was Sturge-Weber syndrome with a normal angiogram. Okay. So my talk is on Sturge-Weber syndrome. So we all know that since it is described by the Sturge and Weber, two physicians, William Sturge and Frederick Weber, and we have the triad of port wine stain. Here you can see the port wine stain, and the leptomeningeal angioma or pile angioma, and usually they will be associated with the abnormal blood vessels of the eye leading to the glaucoma. So that means angioma in the face, angioma in the brain, and angioma in the eye. So that is the triad of Sturge-Weber syndrome. So this is called as encephalo-trigeminal angiomatosis. So each case is unique and exhibits a characteristic finding in varying degrees. So it is an embryological abnormality, developmental anomaly resulting from errors in mesodermal and ectodermal development. So usually the port vein stain will be extending into the trigeminal area, especially the V1 and V2. But sometimes it may be spreading even down into the lower face, trunk, and the mucosa of the mouth and pharynx also. I'll be ending with another case at the end with a different type of presentation, which also may be confused with the Sturge-Weber syndrome. So this port vein stain, again, one must understand that all the patients who has a port vein stain will not be having a Sturge-Weber syndrome. So that means PWS is not equal to SWS. That we all must understand, because port vein stain birthmark can occur in 3 out of 1,000 newborns or 0.3% of newborns. But overall risk of having Sturge-Weber syndrome is only 8% to 15% of those patients who has a port vein stain. And the risk of having Sturge-Weber syndrome increases to 25% when half of the face, including the ophthalmic division of the trigeminal nerve, is involved, and raises to 33% when both sides of the face, including the ophthalmic division of the trigeminal nerve, are involved. So that is it. So that means only 8% to 15% of patients who has a port vein stain will be having. So as soon as a child is born with a facial hemangioma, the parents need not get panicky, because I have seen a number of my colleagues, doctor colleagues rushing to my home, telling that, sir, my child is having Sturge-Weber syndrome. Then I tell them that because only this 15% will be having this problem, we will wait. And the one patient who developed this almost 30 years back, now is a doctor here doing a neurology specialty also. So that means you don't get worried because of just because of a port vein stain occurring on the face. And these are the type of distribution that is described in one of the recent New England Journal article, where patterns of facial port vein stain, because here you can see that one linear type, frontotemporal variety, then isolated cheek and the canthus involvement, combined linear and cheek involvement, see the hemifacial involvement, and the median facial involvement. Usually the significance will be when the forehead involvement of port vein stain is there. For that, a line is drawn connecting the outer canthus of the eye and the top of the ear, including the upper eyelid. So if the angioma is involved in this region, the chances of it being a Sturge-Weber syndrome is high. Still, it need not be Sturge-Weber syndrome because we may have to go for other investigation to confirm it. And large segmental forehead involvement was defined as involvement of the half or more of a contiguous area of the forehead, or a median, that means this purple part. Trace or a small segmental forehead involvement was defined as involvement of less than half of the forehead in the absence of median. And these classifications were used to describe the significance of this PWS with the occurrence of Sturge-Weber syndrome. For example, in this cell, you can see that the first A, they said that patient with a large segmental forehead involvement and the Sturge-Weber syndrome. But this child did not have a Sturge-Weber syndrome and child had only PWS. So that's it. And this patient had a facial hemangioma. And this may be a nevus simplex involving the forehead and the patella. So that means we may have to differentiate a port vein stain from a nevus simplex also. And there can be extension, as I have mentioned, can be there up into the gum region, upper lip or lower lip region. And this patient who did not have any facial involvement, here you can see that only the forehead involvement, facial, but he had a hemangioma involving his upper lip and the gum region. And this patient who had an extension into the lower lip also had involvement. So this sort of a varying presentation also can, and the disfigurement of the lips as well as the gum and the teeth abnormalities also. And here you can see that exact delineation of in the trigeminal region can be seen. So the other manifestations is the eye involvement, where there can be the ophthalmos or a congenital glaucoma, then angiomas involving the conjunctiva, choroid angiomas, then corneal angiomas also can be seen. The eyes can be of two colors also, one brown and one bluish color. Then hydrophthalmos, because fluid-filled orbit is also described as a manifestation of this. And optic atrophy also may occur, or the lens abnormalities, retinal detachment, streaks resembling blood vessels in the retina, that is angioid streaks, and loss of vision, either because of the retinal or a choroid angioma, or because of the involvement of the occipital cortex. We know that because these angiomas, leptomeningeal angiomas, are more common in the occipital region. And because of this, they can have a hemianopsia also. And what are the neurological manifestations? Because of the brain malformations or leptomeningeal angioma, epilepsy may be seen in up to 75 to 55% if it is 75 to 90% if it is a Sturge-Weber syndrome. And most of the patients may develop seizures in the first year of life itself. Unlike in neurofibromatosis or tuberous sclerosis, where the seizures will be more of a epileptic spasms or atypical absences, here more of a focal tonic-clonic seizures involving the contralateral side is described. And many patients may have a refractory seizures in the initial period, but in my experience, almost all of 35 patients which I have collected, except 2 patients, all the 33 patients had good outcome in their seizures. Because in the initial childhood, up to 2 to 3 years, they were having recurrent seizures. Since then, all the patients actually improved, and many were occurring only very small dosage of carbamazepine. And I think 2-3 patients are taking only 100 milligram as an adult, 100 milligram per day of carbamazepine only. And some may have a slowly progressive hemiparesis, because recurrent hemiparesis may come and they may have an established hemiplegia later. Or transient stroke-like episodes, and we have had 3 cases of subarachnoid hemorrhage occurring in a patient with Sturge-Weber syndrome. So these are the neurological manifestations. And as a later sequelae, they can have neurodevelopmental delay, or even frank intellectual disability or learning problem, severe attention deficit disorder, because most of these children were having, even though I was telling that they had a very good improvement, most of them are having attention deficit hyperactivity disorder and at least some amount of learning problems. And some can have increasing cerebral atrophy or hemiatrophy, which can lead to a classical description of a Dyke-David of Mason syndrome, which I'll be showing. And the incidence is around 1 in 50. Inheritance is sporadic, because usually we teach our students that all the neurocutaneous syndromes are inherited in an autosomal dominant manner, and the metabolic disorders are inherited in an autosomal recessive manner. Then you learn the exceptions. So one exception is the Sturge-Weber syndrome, which is only a sporadic occurrence. And usually the incidence of, as we have mentioned, in Sturge-Weber syndrome without facial nerves may be 13%, and bilateral cerebral involvement may be seen in 15%. Already we have mentioned that up to 90% can have seizures, hemiparesis in 25 to 60%, hemianopia may be there in 44%, which may be detected only later, because in young infants and children, we may not be examining for a hemianopia. And developmental delay and middle duration will be seen in 50 to 70%, and glaucoma in 30 to 71%. And Roche has given a scale for the classification of this Sturge-Weber syndrome. According to this type, we can prognosticate also. For example, type 1 is the commonest one with the triad of the skin, neurological symptoms, and most of them associated with the glaucoma. So they will be having facial, leptomeningeal, and the orbital angiomas. And type 2 is there when there is no evidence of a neurological involvement, but skin symptoms and possibly glaucoma, so no neurological symptoms. And type 3 would be isolated neurological variant, where you won't get any skin manifestation, there won't be any port vein stain, but accidentally when we do an MRI, or for we do an MRI for a seizure, then you may detect this. That is a type 3 or isolated neurological variant of Sturge-Weber syndrome. And this one where you can see that there is a severe posterior calcification with a brain atrophy, and increased pneumatization also can be seen there. And what are the radiological manifestations? Because earlier we used to do the skull X-rays, where very classic tram track calcification can be seen. And angiography may show a lack of superficial cortical veins, non-filling of the dural sinuses, and abnormal tortuous vessels. These are described in angiography. CT scanning will show calcification and typical tram track signs, because this tram track calcification means it is people have an idea that it is the calcification of the vessels, but it is not the calcification of the vessels, but it is the boundaries of the gyri. So it is a sort of a gyral calcification, because the borders of the gyri are getting calcified because of the pile angioma. You get when two gyri are sitting together, you get the tram track site, and there can be cortical atrophy, abnormal draining veins, enlarged choroid plexus, and contrast enhancement may be the earliest findings. And as I have mentioned, this Dyke-Davidoff-Mason syndrome, where atrophy, hemiatrophy of the brain, enlargement of the diploid space, the enlargement of the frontal sinuses, elevation of the petrous temporal bone, all these are included in the Dyke-Davidoff-Mason syndrome. And another finding is the calvarial enlargement. And this tram track sign is also described in bronchiectasis also. Okay, and this is my one of our patients, where you can see that very classically you can see that tram track sign, the gyral calcification. You see that the gyra is get, and you see that gyra, the brain itself can be delineated. Yes, you can see in the, I think all of you can see that. See, the brain itself can be delineated by the calcification and by the gyri. And you see the tram track sign, because adjacent gyri is getting calcified. So nowadays, because we may not be doing the X-ray skull, so we may not get a picture like this. Because I always use this for our Viva examination for DM students as well as for MD students. Very typical. And but when we are taking MRI in these days, especially in the infancy itself, or even the newborn stage, we will have to give a contrast to demonstrate the enhancement, especially the leptomeningeal enhancement of leptomeningeal angioma. And what are the findings in MRI? MRI will show gadolinium enhancement of pile angiomas, enlarged choroid plexus. See the choroid plexus enlargement, and then ocular choroidal enhancement, cortical atrophy, accelerated myelination is a very, very characteristic finding on that side. Then SPECT scanning may be shown hyperperfusion in the early phase, followed by hypoperfusion. And I have EEG, but I couldn't incorporate those EEGs into this presentation, where you definitely will be getting a reduced background activity on the affected as epileptic trauma activities occurring on the side of involvement. And these are some of the other typical manifestations. And here you can see that ocular choroidal hemangioma. See, look at the ocular choroidal hemangioma. And here you can see the accelerated myelination, and see that enlarged choroid plexus on that side, and there is a cortical venous enlargement. So these are some of the manifestations. And again, it is said that earlier people thought that the Sturge-Weber syndrome, that when the port vein stain is there and you do an MRI, look for a high signal abnormality in the calvaria. And this high signal calvarial, high signal density may be an indication of an abnormal underlying brain. But now, in one of the study by R.R. Varney et al. In American Journal of Neuroradiology, demonstrate that this calvarial enhancement is not at all related with the brain abnormality, but it is correlated with the skin abnormality rather than the brain abnormality. and that is the intraosseous signal abnormality previously described as related to the pyeloangioma, and hence an early predictor of brain involvement when other findings are absent is not that correct. And here you can see that the finding the left-sided unilateral pyeloangioma in view of the interpeduncular cistern site. So this is again a useful sign to differentiate whether the child will be having a bilateral involvement or a unilateral involvement. Because in bilateral involvement, you can see that there will be bilateral interpeduncular cistern enhancement. So, and this sign is called as a warning sign of Varney-Mangat when it is bilateral. When it is unilateral, so you can see that when it is unilateral, you'll be seeing only a unilateral involvement of the brain also. But here you see the lower picture shows the bilateral involvement and the upper picture shows the unilateral involvement. Again here, as we have mentioned, there can be, so this is a T2-weighted image showing the bilateral volume dose, where there is a bilateral involvement, and see that T1-weighted image showing the, with the contrast enhancement, showing all the features, where the leptomeningeal enhancement is there, brain atrophy is there, and there is a choroid plexus enlargement present. In addition to that, there is a bilateral calvarial signal or a marrow enhancement can be seen here. You see that this is also a very good sign of a Sturge-Weber syndrome. And in this side, because it is bilateral, you are seeing the bilateral marrow findings, bilateral marrow enhancement, and the left-sided dural thickening also can be seen here. See, marrow enhancement as well as the dural thickening. See, inside that we can see the dural thickening also. So the genetic, unlike tuberous sclerosis or neurofibromatosis, we are not discussing much about the genetics because of the sporadic occurrence and no incidence of recurrences. But again, we nowadays know that everything in our human body is now related with genetics. When you are sleeping, you are talking, everything, whether it is a functional activity or a structural activity, the genetics will be controlling it. So here also, in Sturge-Weber syndrome is caused by a mutation in the GNAQ gene. GNAQ gene is the guanine nucleotide binding protein subunit alpha. So that is the GNAQ gene. So this is a guanine nucleotide binding protein GQ subunit alpha. That is why it is called as GNAQ. And this confirmed in samples of affected aberrant sympathetic innervation, increased vascular growth factors, and defects in the extracellular matrix. And it is said that this mutation may lead to the abnormal development of the vascular structures as well as development of the mesodermal structures. So treatment, we all know that it is mostly it is symptomatic. You have to look for the complications. That is more important because glaucoma development has to be monitored periodically. Every month, intraocular pressure must be monitored in the first year. And if there is some changes in intraocular pressure, earlier drugs with beta antagonist eye drops which may decrease the production of aqueous fluid, or a carbonic anhydrase diamox may be used, or adrenergic eye drops and miotic eye drops also may be used. And then the symptomatic treatment, especially when there is a seizures are there, as I have mentioned, most of the cases it is because it is a focal seizure, either by carbamazepine or off carbamazepine, the seizures will be easily controlled. But there are definitely intractable seizure patients are also there. In such patients, we may have to go for a hemispherectomy depending upon the unilateral involvements, and other surgical procedures like focal cortical dissection, corpus callosotomy, or even vagal nerve stimulation for the ketogenic diet, all may be required in those patients who are having an intractable epilepsy. And earlier, when we were seeing a cutaneous portoid state, we'll tell them, nah, this is only a nevus. You just forget it because you don't have any treatment. But nowadays, there is definite treatment is there because the treatment is required for the child, because we know that they will be ridiculed by their peers at the school. So for that, a dye laser photocoagulation is there, which will definitely improve the cosmetic appearance. And then we may have to, we must be looking for other manifestations also. So the prognosis wise, as I have mentioned, it is possible for the port vein strain and atrophy in the cortex to be present even without symptoms also. But they may have a severe symptoms, so we may not be able to predict. But as I have mentioned, if there is more than half of the face is affected, definitely they can have a problem. And early onset seizures, again, maybe a point for an abnormal development. And greater likelihood intellectual impairment and seizures occur before the age of 2 and are resistant to treatment. Now we will have this patient. I think you can see this patient. I don't know whether, again, look at that face on the right side, there is a hemangioma is there. And the patient again was diagnosed as Sturge-Weber syndrome. The child was taken MRI, and MRI patient was referred to us. And again, as I have told you, just like taking the history, I have a habit of examining the patients by undressing them. And when the patient was undressed, I found that there is these hemangiomas were extending to the legs also. You can see that it is extending to the upper arm as well as the legs and also to the trunk. You see that over the legs. And again, you see, can you see the difference? Because on the right side, the limb is large when compared to the left side. So the right side, usually the testis will be large on the left side, but here the testis even was large on the right side. And the measurement, you see that the measurement of the affected side, if it is 17 centimeter, must be centimeter, and see the other one is only 15 centimeters. So definite 2 centimeter difference. Thigh also is around 22 there, and again only 20. So definite 2 centimeter difference. So there is a hemi hypertrophy. Can somebody just shoot the diagnosis here also? Okay, here the diagnosis I think you'll be knowing, because we have a little more adjectives with the Sturge-Weber syndrome, and this is what is called as the Klippel-Trenaunay-Weber syndrome. And here again, look at that X-ray skull. You can see that extensive calcification of the brain matter itself we are seeing, because here identify the tram-drag sign, but again you see that, but here you can identify see the frontal view, that's the AP view. You can see that definite see calcification, the tram and look at, but this was the MRI. See, the child was having a severe lysencephalic malformations with extensive calcification involving all of the brain also. So it was a severe, but still, so this was a case of a Klippel-Trenaunay-Weber syndrome. And we don't know whether Sturge-Weber syndrome and Klippel-Trenaunay syndrome are related disorders that overlap, or whether they are similar at distinct rare disorder, because many times this Sturge-Weber us having involvement of limbs also. And see here, you can right side hypertrophy is there, upper limb involvement also. Look at that involvement of the upper limb also. And it is so it is on the patient's right side, and the calcification is also seen on the right side, more on the right side. And see again, you can see the child with the manifestations there. And in view of the generalized imaginal delay and intraparenchymal calcification, a diagnosis of Klippel-Trenaunay syndrome was considered. And so Klippel-Trenaunay-Weber syndrome is a syndrome combination of capillary malformation, soft tissue or bone hypertrophy, and varicose veins or venous malformation. It is considered as an angio-osteohypertrophic syndrome. The bone involved. Here again, the triad is port vein nevus, bony or soft tissue hypertrophy, and varicose veins or venous malformations of unusual distribution. That is the triad of Klippel-Trenaunay-Weber syndrome. And they can have various malformations, venous dysplasias, arterial dysplasias, arterial associated venous dysplasias, and AV shunt also. When there is an AV shunt occurs as a major manifestation, we have one more syndrome, that is the Parkes-Weber syndrome. Parkes-Weber syndrome, if an associated arterial venous malformation is present, it is called as a Park-Weber syndrome, and some people use the terminology FP-Weber syndrome also, FP or Frederick Park-Weber syndrome. So to conclude, since Anne wants at least 10 minutes, and by telling my mnemonics, which I teach to my students, Sturge-Weber syndrome can be remembered by just remembering Sturge, and usually many children will be requiring a caps, at least a cap which need to cover their hemangioma. So it is the Sturge caps is the mnemonic, where S is for the seizures, and the onset, the inheritance is sporadic, T for tram tract, galliform calcific at the trigeminal territory, then unilateral weakness, because many times they can have hemiparesis, and then they can have mental retardation, glaucoma with the GNAQ, gene abnormality, and epilepsy. The cap where the MRI is showing a calvaeal thickening, choral plexus enlargement, and A for the atrophy of the ipsilateral hemisphere, and pile angiomatosis, and the sinus or a paranasal enlargement. Because if a student knows this, he can write a short note or an essay when he gets a question in the university examination. So I think I'll conclude this. Once again, I thank the organization for Rare Disease Organization, especially Dr. Anne for organizing this program, as well as AOC and executive board members for partnering with this program. And again, I thank IC Verma and Dr. Sandeep Patel for chairing this session. Thank you.
Can we allow a few questions?
Thank you, Kunju sir, for an excellent talk. Now we'll go into Q&A section. So there are a few. Yeah, there are a few questions.
Yeah, we have to hurry up. So,
yeah, yes, sir.
Richard, I have one question for you. What about the use of drugs for neurofibromas? Something like tuberous sclerosis.
Yeah, well, the drugs that we use are things like MEK inhibitors. So we use them mostly for lesions which give us, which are causing problems. So, for example, the patient I showed you who had spinal cord compression, we treated him with trametinib. There are clinical trials on selumetinib, which drugs which sort of block the mTOR pathway. And in fact, the effect seems to be pretty good. They slow the rate of growth and considerably decrease pain. And the other patient I showed you who had a range of pilocytic astrocytomas, he stopped responding to chemotherapy, but when he was treated with trametinib, his tumors also stopped progressing. We think it's a bit like tuberous sclerosis, though, that you sort of are stuck on the medicines, because when I've taken my patients off it, their lesions have grown. The other thing, though, is in one of the patients, certainly treatment seems to decrease epilepsy as well. So you get a similar effect, I think, a bit to tuberous sclerosis, in that there seems to be some biological process which actually drives the epilepsy, which is separate from typical processes of epileptogenesis.
Oh, I have one question also for Dr. Gadgil. You know, the company told me that we are not allowed to use this in India for tuberous sclerosis, the everolimus, because it is not approved by the drug controller. Have you done something about this?
So thank you for raising this question, sir. I think our challenges start much before everolimus. Even vigabatrin isn't officially allowed in India, isn't in Indian FDA approved, and even when we use it for infantile spasms after HIE, most of us are using it.
I think the Neurology Society should do something and take this up.
So there has been a lot of work. That's absolutely so. A lot of work is happening with the TSA Alliance India. They are in communication with the central government. ORDI is associating with the same project. AOCN has made a representation to the DGCI regarding the same. So it's work in progress with respect to vigabatrin getting approved and getting manufactured and marketed in India. And I guess we'll have to do the same for everolimus. So it's work in progress.
Is it possible that they may ask, the government may ask, then FDA, the drug controller may ask them to do a trial in India? That is the only thing.
Yes,
And
sir.
that is what they must be trying to avoid. But this is a very
Absolutely right,
useful drug. We should use all our resources
Yes,
with
sir.
Novartis.
Yes, sir.
Any other question, please?
Yes, sir. There is a next question to Dr. Webster again. This is regarding optic pathway glioma. How do you manage them? And when you start chemotherapy and when you involve neurosurgeon in the management?
So we tend to only treat them if there is visual loss. And in fact, it's got to be a couple of lines of change in visual field tests that sometimes changes. So we don't worry quite as much in terms of change of size on MRI. It actually has to be mostly change in function. There are situations, if you've already lost vision in one eye, where we might treat a bit earlier. And the treatment is chemotherapy, and they tend to respond pretty well to chemotherapy. I don't administer it. I refer them to an oncologist at that time.
Okay. The next question to Dr. Kunju, sir. Sir, are you there?
Yes, definitely.
So role of aspirin in Sturge-Weber syndrome.
Yes. Actually, it is indicated because, as I have mentioned, there is a chance of development of recurrent stroke. But what I do is, in those patients in the early childhood or early infancy, we may give for 3 to 6 months in the early phase. But if only in those patients who are getting a stroke-like presentations, we may go for aspirin. As I have mentioned, because all the patients are with a port vein stain or leptomeningeal angioma may not be candidate for developing all the complications. So only if they have at least one incidence, then only we go for aspirin. As prophylactic, it is not advised.
Okay. Thank you, sir. There is one more question for Dr. Richard. This is by Dr. Umesh Kalane. This is, what is the treatment option for NF1 related CNS vasculopathy? Any role of aspirin and surgery in a NF1 related CNS vasculopathy?
Look, I think there's a role for both, depending upon what's going on. The patient I showed you the images of needed to have a bypass procedure and didn't. I mean, we typically do a vascular flap procedure. Our neurosurgeons do that rather than a direct bypass. I think if you've got as a transitory thing, we tend to put people on aspirin if they've got narrowing and we're worried about their supply. We tend also to do, in addition to the angiogram, we tend to look at the perfusion and use SPECT scans, look at perfusion in the region of the brain just to see whether there is a problem with perfusion. If that's an issue, then we'll consider referring to for surgery. And we tend to do a flap rather than actually doing a direct bypass.
Okay, thank you. Pragna, there is a question for you. In a study where there was a use of a pre-seizure vigabatrin, have they found any visual field constriction in those patients who were on vigabatrin for 2 years? Was there any?
Thanks for bringing this question up. A lot gets discussed about the visual field effects of vigabatrin. As you know, in US, vigabatrin comes with a black box warning because of that. Again, that data is expected out very soon, that the effects on visual fields of vigabatrin are nowhere as common as get loosely quoted when we talk about it. I think Cincinnati Children's should be coming out with that data. So if you see the TSC clinics in US, they have patients on vigabatrin for 15, 20, 30 years. with very dedicated visual checkups, again, age appropriate, age and cognition appropriate. In the younger ones or the cognitively delayed ones, they are doing VPs and ERGs, and in the older ones, of course, they have more formal field checks. And the incidence is apparently very, very, very low. Of course, this isn't published. This is, this is what we keep hearing about in the TSC conferences. But even in that, the specific study, the existing what they're mentioning, that they did not find any visual field, any statistically significant incidence of visual field defects. But of course, remember, these were very little kids. But the anecdotal discussion is that the visual field defect should not be a prime consideration. Of course, you have to keep checking for it, but that shouldn't stop you from offering vigabatrin in the very young, and shouldn't make you discontinue vigabatrin. That's what we used to do. We would give vigabatrin for 6 months, and it's fair enough in infantile spasm, say after HIE. But where vigabatrin has such an important role in TSC, it might be the only drug that you give for your focal seizures or your infantile spasms. And keep an eye on the visual fields, but don't just stop vigabatrin for the purported fear of visual field defects prematurely, because that can cause relapsed epilepsy, as we've often seen, and the problems that come with it. So it's much, much safer than it gets talked about. I just hope the data comes out to substantiate that.
Yes, yes. Thank you, Pradnya. Sir, do you have any other questions? I think we answered most of the questions.
Yes, okay. So we can finish off here.
Yeah.
So I guess you want to thank, or you can thank Sandeep.
Okay, okay. So this was very excellent evening. Actually, we have excellent talks by all the speakers. Those were really in-depth talk. And thank you, Richard, for staying so late for us. That's
thank you very much.
Yeah, that's almost midnight there. Thank you, Richard. And thank you, Pradnya. You were excellent as usual. Your talk was really lucid. And Professor Kunju sir, he was at his best, like always. Thank you, all of you. And thank you, ORDI and Anne, for giving us opportunity to chair this session. Thank you very much.
One last thing. Sorry, there was one question that was not answered. There was something about topical sirolimus, topical application, as well as one question on anticipation of TSC and NF, possible mechanism of anticipation. Open to all the panelists, if anyone could say before we close.
So there is topical everolimus isn't yet FDA approved, but there is a formulation that pharmacies in US whip up, and our really Jugadu parents in India whip up. It's which can be used for topical application, but it's not yet FDA approved, but it's seen to be very effective. With respect to genetic anticipation, I'm going to let the boss, Dr. Verma, answer that question.
Yes,
Dr. Verma, would you like to answer that question, Dr. Verma, about anticipation with NF and NF1 and TSC?
I don't think it's there.
Okay. So if any of the panelists, either they answer or...
I'm not really aware of anticipation as a feature of NF1, so perhaps somebody could cast some light on it.
Same here. I don't think it's seen in TSC as a...
I mean, it tends to be seen in other disorders, which are triplet repeat disorders, but not so much in a monogenic disorder like NF1 or TSC.
Yeah.
So unless there's something I'm missing about the question.
There was also one other question, Dr. Patil, which Dr. Gauri Pasi had asked from Indore about, probably Dr. Richard could answer that as well. Thick corpus callosum associated with poor cognitive outcomes, NF1.
Yes, the answer is it seems to be associated with it. I think it's probably a generalized white matter abnormality, whether it's a problem with pruning earlier on, or it's just there are too many microtubules. But NF1 is associated with abnormalities of development of microtubules, and it may be that there's something abnormal about the axons or the number of axons, but having a thick corpus callosum in our study was associated with worse cognitive performance and more learning difficulties.
Thank you. Thank you to all our moderators and our speakers. Thank you very much, Dr. Richard. It's very, very late in Australia. Thank you so much for staying up for us. And thank you, ORDI. And that's our next talk that was flashed in the background. We've got people from, again, Dr. Ruth Williams and others, Dr. Karna Shekhar and others coming in. Thank you. Good night. Bye-bye.
Thank you. Good night. Very interesting.
Good night. Thank you.
Good night. Take care.